Good morning, everybody. Today we are going to discuss about ECG. I am Vaishnavi from Pharmacy Practice Department. In our fourth chapter in clinical pharmacy, we are going to discuss about the interpretations of the cardiac function test. We have discussed already about different types of diagnostic tools, different interpretations of function test. So here in cardiac function test, we are also going to discuss about 2D echoes. We are also discussing ECG. We will be discussing the biochemical markers of cardiac function. So what type of enzymes are released into the bloodstream when there is a damage to the your myocardial tissues. Here in ECG, it is a unique diagnostic tool because you can record the electrical activity of the heart. No other diagnostic tool has an account for this. Coming to the definition of ECG. So ECG is the abbreviation. It is electrocardiogram. It is defined as the graphical representation of the electrical activity of the heart. That is, graphically you are going to present the electrical activity of the heart. So if there is any conduction problems, in the case of myocardial infarctions, in the case of arrhythmias, in the case of heart blocks and all, you have the significance of ECGs. So these action potentials in your entire cardiac activity will be recorded on the ECG. You have positive deflections, negative deflections, and isoelectrical lines. And this shape and size of these waves, that is the height and width of the waves, so determines both the time as well as magnitude of the action potentials. On the x-axis, it is the time. On the y-axis, it is the magnitude of the action potentials. So what is an action potential is? That is the charges that are being transferring throughout the cardiac activity. So vector is an size as well as magnitude of these action potentials. So in the form of deflections, you are going to see on the ECG graph. So here I have mentioned on the slide, when it is a positive deflection is same charge moving towards the same charge. Positive charge moving towards the positive charge, you get a positive deflection. Positive charge moving away from the positive charge, you get a negative deflection. Negative charge moving away from the positive charge, you get a positive deflection. And when do you get an isoelectrical line? Whenever the charge is, that is, you are not having any transfer of action potentials. When it is at resting position, when the heart is at resting position, you have the isoelectric line. Also, you will have an isoelectric line when there is very slow conductivity, or else you can have an isoelectric line when your action potentials are moving in a perpendicular direction, that is at the 90 degrees angle to the axis line. This dotted line is the imaginary axis line of any lead between any two electrodes. Wilhelm Enthovens invented this ECG in the year 1895. He has won the Nobel Prize for this in 1924. Enthovens' law states that lead 2 is equal to lead 1 and lead 3. Here, understanding about the leads, your ECG is a 12 lead system. You have 3 bipolar limb leads. You have 3 augmented limb leads. You have 6 precordial chest leads. So this is the graph of graphical representation, normal graph in the lead 2. So here you can see, starting you are having an isoelectric line. This isoelectric line is because at the resting position, the action potentials are 0. That is why you get an isoelectrical line. At the resting position, before the starting of the generation of impulses, your heart is negatively charged and you get an isoelectric line. Here P wave represents the atrial depolarization. Here you can see From the SA node, the impulses are generated. You have special type of cells in the SA node, that is pacemaker cells. Your action potentials are generated, and this is the net vector direction. Both your atriums, right and left atrium, are getting depolarized. That is, there is a charge transfer from negative to positive. That is positive charge moving towards the positive charge. You get a positive deflection, that is your P wave. PR segment is the isoelectric line after the P wave. You can see the difference between PR interval and PR segment. PR interval includes the onset of P wave as well as the isoelectric line, that is your PR segment. But your PR segment is only the isoelectric line. So PR segment is the slow conductivity of AV node. Here, after depolarizing both the atriums, the action potentials are collected at the AV node. It is on the basal septum, basal intraventricular septum. Here, this AV node is a slow conductor. For 0.1 seconds, there is slow conductivity. Because of that, the charge is holding on the AV node. You get an isoelectrical line. That is what your PR segment is. Q wave is septal depolarization. Here you can see the arrows. For depolarizing the intraventricular septum, there is a direction change in the vectors of the action potentials. Here, this is the axis line. From negative electrode, you are having on the right arm. Right arm, you are having the negative electrode. Positive electrode on the left limb. So this is the dotted line is the axis line of lead 2. You can clearly see for the depolarization of intraventricular septum, there is a change in the direction. Positive charge moving away from the positive charge, you get a negative deflection, that is your Q wave. Q wave represents the septal depolarization, and this peak R wave is depolarization of apex of the ventricles. So here you can see that is moving towards the total your till the bottom. Your heart is your ventricular apex is getting depolarized. That is positive charge strongly moving towards the positive charge. You get a positive deflection. Coming to this S wave, the negative deflection. S wave is depolarization of bases of the ventricles. So here you can see the arrows, that is for depolarizing the ventricular bases, your direction changes there. Positive charge moving away from the positive charge. You can watch the arrow marks. That is depolarization of bases of the ventricles. You get your S wave. And this isoelectric line, again, your ST segment. ST segment is a gap between depolarization and repolarization. Your entire heart is now positively charged. It is depolarized. Now, from the apex of the heart, you are having the repolarization wave. This repolarization is negative charge moving away from the positive charge or negative charge moving towards the negative charge. You get a positive deflection, that is your T wave repolarization. So your ST segment is a gap between depolarization and repolarization. For an instance, before the starting of repolarization, there is a particular gap. At that point of time, the action potentials transfer is 0. That's why you get an ST segment. You get an isoelectric line, horizontal isoelectric line. T wave represents the repolarization. So repolarization, what happens? Already I have told. Negative charge moving away from the positive charge, you get a positive deflection. Coming to the different leads, already I have told your EKG is the 12 lead system. You have 3 bipolar limb leads, 3 augmented bipolar limb leads. So what is the difference is these negative electrodes are being created by your ECG machine. These are imaginary electrodes. Here in the case of lead 1, lead 2, lead 3. So these are the physical electrodes. Lead 1 is right arm you are having the negative electrode, left arm you are having the positive electrode. This is the imaginary line, axis line. In the lead 2, you are having negative electrode on the right arm, positive electrode on the left leg. So this is the imaginary lead 2 axis line. In the lead 3, you have the axis line between a negative charge on the left arm, a positive charge on the left leg. This is lead 3. Hinterland's law states that, so lead 2 is having three-dimensionally a perfect view of the heart. So this is your heart. This is the imaginary Hinterland's triangle. Here also you can see different angles of the augmented leads. Augmented leads, the negative charges are being created by the ECG mission. So in the center, you have a strong imaginary negative electrode being created. So this is with respect to the positive charge, you are looking at the heart. You are having the positive charge on the right arm, and you are having the both the negative electrodes here, and you can see the arrow mark. So that is the direction at which your augmented leads, vector leads, are looking at the heart. Here this is augmented vector right, so it is exactly opposite of the lead 2 because of the placement of positive electrodes. So in the augmented vector right, you have that is inverted p waves. All the r wave is also inverted, and s wave is having a positive deflection. That is exactly opposite of your lead 2. The graph looks like that. Augmented vector left, here you are having on the left arm, you are having the positive electrode. These are the two imaginary electrodes. So this is the vector direction. Your action potentials are being seen through this lead. This is augmented vector foot. Here you are having on the left limb, you are having your positive electrode. These two on the left and right arms, you are having the creation of negative electrodes. At the center, you are having imaginary negative charge. So you are looking at the heart in different directions. Coming to the chest leads. So these are all positive, unipolar. No, it is not having, unlike your limb leads, it is not having two electrodes. These are all single positive charged electrodes that are placed on the chest. So see the placement of these precordial chest leads. V1 you are placing on the right side of the sternum, on the your right parasternal line. You are placing this one in the fourth intercostal space. So this is the fourth intercostal space. 1, 2, 3, and 4. Fourth intercostal space, on the right parasternal line, you are placing the first positive electrode, that is your V1. So moving, this is your sternum. You are moving towards the left side. Here V2 you are placing on the left parasternal line. So here it is the right side, this one is the left side, same on the same intercostal space, that is fourth intercostal space towards the left, you are placing your V2. And before placing V3, you have to place your V4. So V4 is placed, that is also left side, on the move down, that is fifth intercostal space. You are placing your V4 on the mid clavicular line. And in between this V2 and V4, you are placing your V3 symmetrically on the fifth rib. 1, 2, 3, 4, 5. Fifth rib, between V2 and V4, you are placing your V3. Later, if you, after the V4, you are placing your V5, moving towards the, that is anterior axillary line. Left side of the septum, you are placing this V5. Further moving towards the your mid axillary line. Mid axillary line, you are placing your V6 on the same fifth intercostal space. This is the placements of your chest leads. What is the difference between the limb leads and chest leads is, limb leads are looking at the vertically, they are looking at the heart vertical direction. So this chest leads are looking at the horizontal direction, or in the transverse plane. they are looking at the electrical activity of the heart. So this is about the your placements. Already I have explained. So in the transfer section, if you look at the placement of the chest leads from V1 to V6, it looks like this. This is commonly which angle they are having, which lead is having the access to which part of the heart. You can see inferior walls are being covered from lead 2, lead 3 and augmented vector foot, whereas lateral wall of the left ventricles are seen by lead 1 and augmented vector left and also V5 to V6. Augmented vector right, V1 and V2 precordial leads are looking at right ventricles. V1 to V4 they are looking at the anterior-septal area. So in the interpretations, you have the ECG like this. You have lead 1, lead 2, lead 3 and augmented leads and 6 precordial leads, and lead 2, because of intervention triangle, we are taking a rhythm strip, that is for about 10 seconds continuously we are going to observe lead 2 for determining the rhythmicity. So to diagnose any type of arrhythmias, this rhythm strip is used. Here the normal heart rate, so we are considering it as the minimum is 60 beats per minute, the upper limit is 100 beats per minute. So anything less than 60 beats per minute is considered as bradycardia. Anything greater than 100 beats per minute is considered as tachycardia. You have two methods, that is box method and R wave method. I have given on the screen, just go through it. So here R wave is very simpler. In the rhythm strip, about 10 seconds, how many R waves you are getting, count the R waves and multiply it with 6, you get the how many beats per minute. Here one example I have given of bradycardia. Here box method also I have given example how you are going to calculate the number of boxes between the R wave. Coming to the rhythm, that is if it is regular or irregular. The RR interval, if it is constant or not constant, so determines the regular or irregular rhythm of the heart rate. In the rhythm strip, we are going to check for this. If it is constant, then it is regular. If it is not constant, changing, it is irregular. So QRS complex, if you see in the ECG, you are having smaller boxes and larger boxes. So each smaller box, the width determines on the x-axis, it determines the time, and each small box consists of 0.04 seconds. If you multiply it with 3, so you get 0.12 seconds wide. That is QRS complex. Your activity in the electrical activity in the heart is about 0.12 seconds. That is your QRS complex. The normal should be less than 3 small boxes. The width should be less than 3 small boxes. If it is exceeding the 3 small boxes, it is considered as wide QRS. Coming to the sinus rhythm. So what is a sinus rhythm is the rhythmicity of the heart. That is the P wave should be present, and this P wave should be upright in the lead 2 and it should be inverted. I told you opposite. Your augmented vector right is opposite. Every P wave is followed by a QRS. So this is the sinus rhythm. That is rhythmicity is maintained properly. See the definition, that is sinus rhythm is the name given to the normal rhythm of the heart throughout the transfer of the action potentials in the rhythm strip. The next one is PR interval. PR interval, what is its representation? PR interval is due to slow conductivity of AV node for about 0.1 seconds is normal. So PR interval, if it is exceeding, if it is prolonged, so it is significant in the case of heart blocks. So different types of first degree, second degree, third degree heart blocks, you can it is significant in that case. So I have given the normal range, that is it should be less than 0.2 seconds. PR interval. So why I'm telling you 0.1 seconds is PR segment, and we are including the P wave in the case of PR interval that is significant in heart blocks. It should be less than 0.2 seconds. So this is about the basic understanding of ECG. Further, we are going to look into different interpretations. That is, in the case of different types of myocardial infarctions, in the case of different types of arrhythmias, in the case of heart blocks, in the case of the diseases related to tachycardia and bradycardia, we are going to discuss in the further classes. Thank you.